Welcome to a new video tutorial of the DIERS International. Great to have you on board. The spinometry device DIERS Formetric 4D is the core product of our product line. Since its introduction to the market back in 1996, it has been able to convince a big number of clinicians all over the world to including this posture assessment tool to their daily clinic life and embrace the information the principle of video raster stereography is able to deliver. This video is an introduction to the result interpretation of a formetric examination and is meant to set the reference for a better insight of its basic clinical meaning. In addition, it ensures a good understanding of the cases you can also watch on this platform. So, without further ado, let's start with this session. The result pages of a formetric measurement are divided into different main topics via different tabs. However, most pages have a similar structure. In the upper left corner you will find a table that lists the parameters relevant for the respective tab. If you would like to highlight one or more parameters for a later point in time, you can simply click on them with the right mouse button and highlight each with one of the three color tones. This marking is retained for the corresponding measurement. In addition, you can pull up an illustrated explanation by double-clicking on a parameter. This may assist you in interpreting or communicating your findings to a patient. Close the window by clicking on the X. Alternatively, this function is available by hovering the mouse over the question mark symbol to the left of the respective parameter. Please note, however, that you need a steady hand and a monitor that is not too small. To the right of the table is the image of the stripe projection. This is used for subsequent verification of the measurement procedure. Thus, it can be seen here which areas of the upper body were covered by analyzable stripes and whether a complete 3D model can be calculated from this, which is the direct basis for the 3D model at the right side of the screen. The three-dimensional model of the back and the anatomical model of the spine are the graphical core of the calculations. The accuracy with which the surface is represented here is about 0.1 to 0.2 mm per measurement point in the XY plane and 0.3 mm in Z direction. Anatomical fixed points, VP, DL and DR, are placed with an accuracy of about 0.9 mm, resulting in a shape-related deviation in the bony model of the spine of about 2 to 3 mm in the coronal plane and 3 degrees in the transverse plane. These numbers may seem a bit high at first, but they are absolutely in line with the expected accuracies on an X-ray or an MRI system. Various buttons above the 3D models allow you to customize the graphical representation. Try to trace the surface structure via the mean or Gaussian curvature. What can you see there? The mean curvature colors concave areas blue and convex ones red. It uses an horizontal approach for this. If we look at the course of the stripes from left to right, we see protrusions and depressions. This is the logic according to which the coloring takes place. Thus, the local expression of the concavity of the lumbar dimples and the convexity of the spinous process of C7 can be recognized very well on this model. But soft tissue-related imbalances also stand out well here. Like the mean curvature, the Gaussian curvature represents concave in blue and convex in red. The approach considers not only the surface course from left to right, but also the course from cranial to caudal. Only the areas that are clearly defined in both directions of observation are colored red or blue, and indifferent areas are colored green. The principle can be illustrated somewhat using the example of thoracic kyphosis. A fingertip guided from one axillary point to the other moves into a local depression at the level of the spinous processes. This results in a blue coloration in the mean curvature. If the fingertip now descends from C7, it presumably meets the convex structure of the kyphosis. This results in a concavity in the horizontal and a convexity in the vertical at the same point. This leads to the green coloring in the Gaussian curvature. Furthermore, you have the option of replacing the anatomical spine model with an abstract one. This is often a much more understandable representation for your patient. Choose from predefined standard views or rotate the model by dragging the mouse in any direction while holding down the left button. Of course, you can also reset the view automatically. You may use the advanced options to select or deselect additional graphical displays. Fixed points and spinal lines are already selected. Below that, the stripes of the stripe projection can be shown, three-dimensional grid or a moire topogram. In interpolated form, the topogram highlights superficial asymmetries. In the example, it is easy to see that the right scapula protrudes slightly more towards the measuring unit than the left. This fact can be shown even better using the layer drawing function. Here you can see, for example, that the right arm is also twisted. The 3D crosshair has no clinical relevance. It is only used for subsequent verification of the acquisition quality. The position of the crosshair corresponds to the position of the calibration plane of the stripe projection. Where the three axes meet is the center of the middle stripe in the pattern. And this is exactly at the measured optimum distance. Thus, it is easy to see whether a patient has been positioned at the correct distance or whether the stripe projection has been set to the correct height. The first result page tab opens an overview of all three recording planes. This is then how the selection of the graphs is compiled. On the left side is the lateral projection as an expression of the spine's course in the sagittal plane. The green line reflects the sagittal course of the spinous process line. The blue line is the line connecting the centers of the vertebral bodies. The zero line represents the vertical plumb line in the lateral view under VP. From the clinical point of view, the relevance lies mainly with the green line, since the sagittal parameters in the table are derived from it. Kyphosis and lordosis angles are derived from the inflection points, the trunk inclination from the surface points VP and DM. In addition, the green line with VP offers an absolute 0 point as a reference. In addition to the absolute values of the parameters, subjective impressions can also be helpful in the final findings. Over what length does the lordosis extend? How harmonious does kyphotic shape look? Can you detect longer vertical alignments? Then a quick word about sagittal imbalance. This can usually be derived well from the position of the lordotic apex. Normally, the LA is expected to be directly on the zero line. This corresponds to a neutral torso inclination of about 3 degrees. If the lordotic apex is to the right of zero, an inclined posture is present. A lordotic apex to the left of zero corresponds to reclination. In the table, an A for anterior and a P for posterior is added to the value of the sagittal imbalance. The mid-graph of the frontal projection shows an exact PA view of the line through the vertical bodies with the blue line. A convexity to the side is called a lateral deviation. The parameters apical deviation, VPDM, plus and minus max are listed in the parameter table for this purpose. Plus max shows the value of the maximum lateral deviation to the right, and minus max shows the maximum deviation to the left. The segmental level of the maximum deviation is added to the values. Of course, it makes sense to look at the values of the maximum deviations, but subjective impressions can also help to deepen knowledge here. So is the deviation short or long-arched? The former can possibly speak for short-term postural reactions like blocking or evasive postures. It should be emphasized that jack changes in direction in the course of the curve can have a high stress potential for the underlying structures. An elongated curve is more likely to be found in longer-acting full-blown compensations. For example, more advanced scoliosis is more likely to be measurable by the deviation extending over a larger segment. The graph is fixed cranially to VP so that the zero line of the coordinate system represents the vertical plumb line of VP. This brings us to the second tabular parameter, coronal imbalance. For better emphasis, a red dashed line is still visible in the coordinate system. It directly connects VP and DM. If the line deviates at the lower end from the 0 point, we speak of coronal imbalance. Thus, if DM is to the left of 0, this is quantified as coronal imbalance to the right. The plumb line then falls to the right of DM. Let us move on to the third graph, surface rotation. Mathematically, surface rotation reflects the transverse orientation of the line of symmetry on the surface, hence the name. A bit abstract perhaps, but if you understand that one of the main assumptions of the calculation of the spine model is that the spinous processes always align with the symmetry of the trunk, which is what the symmetry line represents, then it becomes clear that the transverse alignment of the symmetry line is nothing more than the rotation of the underlying spinous processes. If the graph runs sideways from the zero line, we speak of a surface rotation. A course to the right means a spinous process rotation also to the right. The corresponding vertebral body lies in front of the axis of rotation and rotates in the opposite direction. This is also how the counterplay of lateral deviation to the left and surface rotation to the right, which is visible here, arises. A segment deviated to the left rotates with the vertebral body in the direction of the deviation, so the spinous process then points to the opposite side. The maximum rotations are presented in tabular form. Plus max shows the value of the maximum surface rotation to the right, minus max then for the maximum rotation to the left. Here too, the respective segmental level is added to the values. The same applies to surface rotation as to lateral deviation. Subjectively, a distinction can be made between short and long arch deviations. In the case of short, tight, directional changes, a high structural load can be assumed, which manifests itself, for example, in soft tissue tension in this area. This is often associated with an increased energy expenditure. Long arch rotational trajectories are usually the result of a longer history of compensation and dysfunction. A short arc is commonly related to a short-term reaction that has turned into an adaptation and realignment that is able to meet everyday mechanical and functional demands with reduced energetic expenditure. A special feature becomes clear in this graph. The lower end always runs to zero. This is the effect of the so-called pelvic correction, a computational procedure that rotates the entire three-dimensional model of the back against the spatial rotation of the pelvis. So, if we find a pelvis that opens 5 degrees to the left, which is a pelvic rotation to the left, the pelvic correction causes a 3D model to rotate 5 degrees to the right. This effect can also be seen in the 3D model displayed on the right-hand side of the image. What does it mean? First, it does not matter if the patient was standing rotated to the exposure plane due to a positioning error. The pelvic correction is able to calculate this out. In addition, the functional orientation of the spine to the pelvis can be recognized much better this way. Here it is irrelevant whether the spine rotates above the pelvis or the pelvis rotates below the spine. What is important is the arrangement of the spine in the symmetry or asymmetry. This can then become apparent with pelvic-corrected view. A muscular imbalance can be more easily deduced. However, the most important argument of the pelvic correction is the establishment of reproducibility. Via the zero position, every surface rotation, whether intra or inter-individual, is at the same starting point and thus offers the best comparability. Finally, a quick word about the core parameters for the pelvis on this results page. Pelvic obliquity refers to the difference in height between the left and the right lumbar dimples. It thus provides a clear difference to the clinically determined value of pelvic obliquity. In the parameter table, therefore, the side of the higher dimple is always highlighted. In the clinical context, please do not confuse the pelvic obliquity with a leg length discrepancy across the board. This may be reflected in a pelvic obliquity, but it does not have to be. A structural leg length difference acts in a complex interaction of pelvic obliquity, twisting and rotation. But also the geometry of the leg axis and the alignment of the foot are strong negotiating partners here, which do not allow a leg length discrepancy to be determined via a single value. But of course there are simple approaches. If you detect a pelvic obliquity in a neutral measurement of your patient, you can quickly check the effect of a shortening compensation using an underlaid wooden board or the automated DIERS simulation platform in a follow-up measurement. Here you not only see how the pelvis reacts, but you also get an impression of how the stimulus affects the rest of the spine. An important parameter here is also the pelvic torsion. Pelvic torsion is an expression for the ventral or dorsal tilt that can exist between the right and the left innominate. Graphically, the pelvic torsion can be derived from the two surface normals which point out at right angles from the maximum dimple concavity. If the arrows are parallel to each other in the sagittal view, there is no twisting of the innominates. In this case, the pelvic torsion is equal to 0. A pelvic torsion with the side indication left would mean that the arrow in the L is steeper than the one in the R. However, it cannot be concluded from the value whether this is then associated with an anterior left innominate or a posterior right one. Based on the studies known to date, there are only extremely narrow tolerance limits for pelvic torsion. Thus, a torsion of 3 to 4 degrees can already represent something to take a closer clinical look at. In any case, the development of a pelvic torsion during the previously described simulation of the shortening compensation must be considered. No matter how other parameters develop in this process, a worsening of pelvic torsion is rarely an acceptable reaction. Let's move on to the sagittal plane tab. After we spent a very long time in the previous tab, it will now get a bit shorter. You already know the basic page structure and we have already discussed the core parameters. In the parameter table of this tab, some secondary parameters are added. These include the inflection and apex points. The respective parameter value first shows the distance of the point from VP to the nearest millimeter. More clinically interesting is probably the indication of the segmental level. The cervicothoracic junction, described here as ICT, abbreviation for inflection point cervicothoracic, is expected slightly caudal of VP. The apex point of the thoracic kyphosis, Ka, is normally at T7 or T8. The thoracolumbar junction, ITL, abbreviation for inflection point thoracolumbar, is located at T12 L1, and the lordosis apex LA is found at L3. The last transition, ILS, inflection point lumbosacral, shows the lumbosacral junction usually at the level of the M. A deviation from the above segmental position indicates a functional shortening or lengthening of a curvature. This can have noticeable effects on the sagittal load distribution. If, for example, the kyphosis apex is not found at T8 but lower to T10, this will also shift the point ITL caudally. The first logical response will then be to derive a higher kyphosis angle. In sagittal logic, hyperkyphosis then would also be accompanied by an increased demand on a lordotic shape to maintain sagittal tensegrity and stability. However, because of the lowered ITL, this requirement must now be met from a smaller number of segments. This can be a strong stressor for the lumbar structures. The parameters flesh cervical and flesh lombaire will be explained later at a more appropriate place. If we look at the graphs, on the left we see again the lateral projection. In contrast to the previous tab, here it is shown with the points described above. But it gets highly interesting with the graphs of inclination and curvature displayed next to it. The specification of the sagittal parameters kyphosis and lordosis is written down relatively globally. Due to the position of the calculation points, it can happen that a critical course between the measurement points is not considered by these parameters. A high kyphosis angle can run flat between the then very steeply running measurement points ICT and ITL, which in individual cases may be much more interesting in imaging when it comes to comparing postural metrics and physical symptoms. For this, the inclination can give you just the right answer. The inclination basically tells you whether a segment is tilted forward or backward. An anterior tilt or flexion corresponds to a positive tilt, and a posterior tilt or extension corresponds to a negative tilt. Where the graph passes the zero line, a segment is parallel to the ground. For a better understanding, a short excursion into biomechanics will now follow. If we take a look at the sagittal construct, one of the most important tasks of the sagittal alignment is the absorption of the ground reaction force during walking. Here, the ground reaction force acts upward and must be completely buffered until it reaches the upper cervical structures and the upper cervical joints. In the sense of energy-efficient shock absorption, this process should be distributed over as many segments of the spine as possible via minimal force application. This is possible when adjacent segments are at a tilted angle to each other, over which the force vector can be redirected. If adjacent segments are parallel to each other, the force vector can break through to the next segment behind it. This faulty principle is well known in patients who have been treated with a spinal fusion. In many cases, this treatment can calm an unstable and painful level and permanently alleviate the symptoms. In many cases, however, indirect recurrences occur. not in the treated area but in the immediate vicinity of the proximal end of the fusion. There, a higher mechanical load is created when this segment must do the additional work of one or perhaps more segments. But there is no doubt that this takeover is happening. If it would not take place, the head would wobble back and forth with every step and the field of vision would lose its alignment to the horizon. Maintaining this alignment is, however, one of the highest maxims of the physical autoregulation and is found intact with the vast majority of the human population. Following this principle, it means that the graph should consist of a primarily diagonal course in the optimal case. Conspicuous parallel positions are characterized by a vertical curve. Try to match local complaints and local clinical findings with the curve. How often does your clinical impression coincide with this view? The curvature on the right side shows, clinically speaking, the shift of each segment in an anterior or posterior direction. Since all levels are in relation to each other, the noise of a larger section is expected to remain at a constant level. To make the description a little more figurative, place your index finger on the spinous process of C7 and travel down the spinous process line from there. Over a spinous process, your finger travels over an elevation between two spinous processes into a depression. Along this path, the finger travels in a steady back and forth motion. If a segment stands far anteriorly, the elevation flattens. Likewise, it increases if there is a posterior shift. Local soft tissue retractions increase the deepening. The finger moves further anteriorly. Mathematically, we speak of a positive curvature in the thoracic kyphosis and a negative curvature in the lumbar lordosis. These target ranges are highlighted in gray on the graph. The height at which the gray area changes sides corresponds to the individual thoracolumbar junction. Here too, a lengthened kyphosis or a shortened lordosis could be quickly recognized. But what can we look for in the concrete graphical course? The curvature should be positive, but is locally negative, so a deflection in the wrong direction. The deflection of the graph assumes the correct direction locally but exceeds the range of the other section levels. In these cases, a muscular block may be expectable, but it may also justify a suspected diagnosis of a spondylolisthesis. Very unsteady courses may be indicative of segmental instability. Very low back and forth movement instead may indicate increased rigidity. In the parameter table of the transversal plane tab, known parameters are displayed in new forms. In the case of both surface rotation and lateral deviation, it is quite interesting to consider an average deviation over the entire course of the spine. However, both are parameters that can have positive as well as negative characteristics. In a mean value calculation, these cancel each other out. To avoid this effect, a sign-adjusted mean value, the so-called root mean square or RMS for short, is used instead. In addition, there is the amplitude. This is the sum of the maximum deviations of a parameter to the right and left. About the rest of the display. At the bottom left, you can see the cross-section. This shows the transverse view of the stripe plane colored red in the upper stripe image. The plane is also drawn in the 3D model on the right. You can change the displayed level by scrolling the mouse wheel or by using the up and down arrow keys. To work with the mouse wheel, the mouse pointer must be over the striped image. The displayed cross-section has a crosshair, whose 0 point is the exact surface point of VP. The yellow line represents the connecting line of the lumbar dimples. This is always parallel to the x-axis in the first display step, which is derotated by the pelvic correction already mentioned. The red line shows the course of the surface in the transversal plane, and the green dot is the corresponding part of the symmetry line. The blue dot represents the center of the vertebral body. The viewing direction can be changed via the icon at the bottom left. By default, the patient lies prone and is viewed from caudal to cranial. Via the button above, you finally have the possibility to see to what extent the pelvic correction has been applied. If you click on this icon, the graphic will show the pelvic rotation. If this is present, you can clearly see how the entire cross-section, including the yellow line, rotates against the direction of correction. If, for example, the right ilium moves anteriorly and the left ilium posteriorly, there is a pelvic rotation to the left in this case. This value is then also found in the parameter table. So, what is the difference between pelvic corrected and pelvic uncorrected? The uncorrected view shows you how the patient was positioned in space. If his feet have been positioned orthogonally to the device, you thus see the real spatial rotation position. However, since it is likely that the spine will compensate the pelvic rotation in order to maintain the horizontal alignment of the eyes, the asymmetry required for this against the real rotation is not quite easy to understand. For this reason, in the set comparability, the pelvic corrected view is usually preferred. The posture profile allows further consideration of the sagittal situation. An angle-neutral relationship between thoracic kyphosis and lumbar lordosic is calculated via the parameters flesh cervical and flesh lombaire. The principle goes as follows. If a person stands with his back against the wall, he touches the wall with the kyphotic apex. The points that have the farthest distance from the wall are the lordosis points in the lumbar spine as flesh lombaire and cervical spine as flesh cervical. The ratio of these two values to each other can allow the naming of the individual sagittal profile. However, there is a major catch in this calculation. The lowest point of the cervical lordosis cannot be detected by the device in most cases. Thus, there remains some ambiguity about the flesh cervical given in the table. For this reason, and for the reason of a simpler basis, it is easiest to use an alternative point. This is displayed in the middle graphic and measures the distance from VP to the wall instead. This solves two problems at once. First, VP is always measurable. Second, the clinical comparison between flesh cervical and flesh lombaire is much easier to make. The approach presented on this page has a rather shadowy existence in the German-speaking world. A short description is given in the Orthopedic Diagnostic by Hepp and Locher. Here too the alternative variant is described, which can be viewed on the results page Report. As can be seen there, the definition for determining a normal back is a flesh cervical and a flesh lombaire of about 30 mm, so the same length. This makes the classification a little easier. Note, however, that it rarely happens that the values or even the ratios match the definition at 100%. We then speak more of tendencies. This result page once again places the 7 core parameters in a normative context. Green are minor deviations, yellow are deviations of moderate degree, and red are deviations of a high degree. However, you should be warned against the stubborn of this view. The many clinical experience values of the past 25 years have clearly shown that isolated deviations do not always have to be pathological. With a multitude of bones and joints in the human body, the norm is defined by deviation rather than perfect symmetry. In addition, there are interactions between different postural parameters. For example, an increased surface rotation usually comes with a noticeable lateral deviation. Overall, this page is certainly quickly understandable, but to communicate carefully to your patient. The specification of a scoliosis angle and an approach comparable to the determination according to Cobb has been one of the most frequently requested features in the clinical user field for several years. So how does the calculation according to DIERS work? In the course of a scoliotic profile, segments perform lateral flexion. The segments of the spinal model that are most inclined to the side in opposite directions are detected in the first step. The second step then calculates the opening angle formed by the two lateral inclination angles with respect to each other. So the basic calculation is therefore identical to the calculation according to Cobb. So where is the difference? The difference lies in the consideration of the skeletal formation. When determined by an X-ray, the concrete structural situation is present, deformed end plates, wedged vertebrae, etc. This morphological damage cannot be captured by the video raster stereography and is therefore represented in the model by a morphologically intact bone structure. In addition, DIERS performs a three-dimensional view and always orients the drawn tangents to the segmental rotation as well, a circumstance that is impossible in the radiograph. For this reason, the DIERS scoliosis angle and the Cobb angle must have different characteristics. Due to the variable morphology, a standard offset factor is also not possible. So, how can a clinical application be made? At the beginning of a scoliosis diagnosis, there is an obligation to perform imaging diagnostics by X-ray. By taking an image with a photometric directly afterwards, an individual correlation value can be determined that quantifies the difference between the two angles. Based on this, the scoliosis angle can be used first in follow-up examinations. When there is an indication of structural changes, the X-ray may be checked and then, if necessary, the correlation factor revised. So this concludes our today's tutorial video. I hope you were able to take away some interesting information. So stick with it and stay tuned for the next tutorial.